Hi, my name is Tariq Adar, and today we'll be talking about the physiology of primary hemostasis. Then we're going to talk about some of the pharmacological targets for primary hemostasis, mainly dual antiplatelet therapy, and then we are going to talk about some selected pathophysiologic disease states. So when we say primary hemostasis, let's define what we're talking about. We're not talking about the coagulation cascade, and we'll look at the coagulation cascade in a minute. But that's not what we're going to be focused on today. We're just going to review coagulation in one slide, and then the rest of what we're talking about is going to be involved with platelets, the endothelium, and von Willebrand factor. When we talk about primary hemostasis, those are our three players. What's primary hemostasis? The initial bleeding control response. All right. So in the intrinsic path, there's two pathways to the coagulation cascade. One is intrinsic, meaning it occurs in the absence of a plasma membrane signal. The other is extrinsic, meaning it requires an interaction with something like tissue factor from cells. So let's say an endothelial cell is injured. You have tissue factor expressed by cells, and here's the endothelium, and factor 7 will be activated by this injury, and then it binds to tissue factor. All right, that binding to just to recap, because there was a lot there. There's an injury to the endothelial cell. This exposes factor 7 to tissue factor in the cell. All right. The combination of tissue factor exposure as a result of the injury to the endothelium and the activation of 7, hence 7A, leads to this complex here. And this complex converts factor 10 to factor 10A. What you'll notice is in both pathways, extrinsic and intrinsic, they converge on 10A. So factors 10, 5, 13, thrombin, prothrombin, all this stuff is the same. That's why it's the common pathway down here. All right, we're not going to go into the itty gritty. There'll be a different video talking about all this stuff. I just wanted to point out the first thing is endothelial injury. And the reason why I'm emphasizing this is because this is what goes hand in hand with what we're going to talk about for the rest of the, what do you call it, for the rest of the lecture. Okay? And the other important part that goes hand in hand with what we're talking about is not necessarily this part of the intrinsic pathway. What I want to draw your attention to is 8 to 8A. All right, so thrombin converts factor 8 to factor 8A. So just because we started with the extrinsic pathway and that led to the common pathway, that doesn't stop the common pathway from causing a forward feedback loop. So the thrombin from the common pathway comes back to the intrinsic pathway. And in the intrinsic pathway, that thrombin that was generated by the extrinsic pathway will convert 8 to 8A. And as we're going to learn, there's a component of primary hemostasis, the platelet-von Willebrand collagen, sort of that group called primary hemostasis. The von Willebrand factor is going to stabilize 8. All right, so to summarize everything on this slide, injury leads to binding of 7 to tissue factor in the form of 7A. That will activate factor 10, and then you get the common pathway. The thrombin from the common pathway can activate, all right, it can activate factor 8, all right, in a forward feedback loop. It's a forward feedback loop because in biology, forward feedback loops are required when there's an event that must be seen to completion. Clotting is a good example because you must complete the clot. Another example would be birth, oxytocin, and uterine smooth muscle contraction. The more the uterine smooth muscle contracts, the more oxytocin is released. The more oxytocin is released, the more the smooth muscle contracts. And that's because you have to get a baby out of there. It's an all or nothing. And clotting is all or nothing. You don't want to kind of clot. No, you want to clot. All right, here's primary hemostasis. I know this looks terrifying right now. By the time we're done, this will be easy for you to memorize and remember. All right, but let's work through the diagram once. Let's focus over here on the normal physiology. Normally, the endothelium is healthy. It releases, smooth muscle relaxing factors, etc. It's non-vasoconstricted, but something can happen that activates it, okay, or sends injury. Now, something I want to point out here, that response to the injury can be appropriate as in, oh, there is bleeding, so my endothelium needs to activate so that we can constrict and clot, right? You want to constrict to reduce the amount of blood going through the area that's injured, and you want to clot it. However, because our body is kind of dumb in regards to inflammation, which it uses as, oh, I'm injured, inflammation. Inflammatory states can cause activation of the endothelium in the absence of any other stressor. All right, so activated unhealthy endothelium, which is brought on by a lot of inflammatory states, one of those being smoking, and that includes electronic cigarettes, vaping, and water pipes. Smoking is smoking. That damage to the endothelium from the just generalized inflammatory response activates the endothelium. In fact, severe infections activate the endothelium. All right, and that can cause clotting. Severe infections can cause clotting, and that's called disseminated intravascular coagulation. We're not going to go into that, but the main emphasis we're making here is that any insult to the endothelium, whether it's in the form of bleeding or inflammation, activates the endothelium. All right, so if the endothelium is injured such that the collagen and microfibrils are exposed, so these are normally under the endothelium, right? You have your endothelium that can be activated or not, but even under the endothelium is a subendothelium that contains some of the connective stuff like collagen and microfibrils, and then that gets exposed, okay? The other thing that happens is that activated endothelium has these storage granules that release von Willebrand factor, these multimers of clotting factor called von Willebrand factor. Okay, and what the von Willebrand factor does, and we're going to go through all of this again step by step with images in a bit. And what the von Willebrand factor does is that it binds to the collagen. Okay, so if you think you have your collagen, it's exposed, von Willebrand factor binds to the collagen. And then from on one side, and then from the other side, the von Willebrand factor binds the platelet. And the platelet has its own receptor that has to not just bind to von Willebrand factor, but bind to collagen. And then the endothelium is also releasing a bunch of inflammatory stuff like thromboxane, et cetera, a lot of inflammatory markers, and that also activates the platelet. So the result of this, okay, the result of, after all this stuff happens is that the platelet is activated. They release ADP, thromboxane, very important, ADP, thromboxane, more von Willebrand factor, fibrinogen, all this stuff, and they clump together. All right, and we'll see how they do that. Okay? But I really want to emphasize thromboxane A2 and ADP because those form the hallmark of dual antiplatelet therapy, the whole reasoning behind it. Now, once the platelets all come together, they sort of cross-link the fibrinogen. They bring a bunch of I don't want to use the word cross-link, but they form bridges, is probably a better way to put it. So a platelet has fibrinogen, and that fibrinogen is attached to a platelet, and then that platelet has some fibrinogen attached to another platelet. So it's more like a net. I think net is a better phrase than cross-link. Cross-link implies, something more direct chemical covalent modification. Here we're talking more of a receptor-receptor interaction. Okay, so it forms more of a network of platelets and fibrinogen. Not fibrin, fibrinogen. Okay, remember fibrinogen is the zymogen. It's the inactive form of the protein. Now, platelets, this net that we just described, that's where the coagulation factors will act. So without primary hemostasis, you don't get secondary hemostasis. And that'll be an entirely different lecture. So let's go back up to von Willebrand for a moment, okay? But that was it. That was primary hemostasis. And we're going to review this step by step in detail in the next slides. So there's two ways you can lose von Willebrand factor. It's either genetic or it's acquired, and we'll talk about it. That gives you von Willebrand disease, right? And if you don't have functioning von Willebrand factor, you don't get any of this. If you don't get this, you don't get anything that comes after. All right, and then you also have Bernard-Soulier syndrome, which is similar, except it's a problem with the receptor on the platelet that recognizes the von Willebrand factor. All right, so how does primary hemostasis, this disorder, how does it present? We're not going to talk too much about the clinical picture because that's not the purpose of this. This is a physiology lecture, but it's important to know that because it's a problem with a platelet plug, what you're going to see is a lot of mucocutaneous bleeding. So you're going to see it in the skin and in the mucous membranes. So vaginal bleeding, scattered petechiae, so these pinpoint lesions, and nose bleeding or epistaxis. All right, and there'll be wounds take a long time to close, and the wounds bleed excessively. So your bleeding time, the time you spend bleeding, is prolonged, and the time it takes to close the wound is prolonged. All right, and it's because you can't form a plug. And look down here, drugs like aspirin and NSAIDs inhibit thromboxane A2 by inhibiting cyclooxygenase and thereby inhibit platelet aggregation. Now, what I want to point out what that means, because we're going to talk about it later, so I might as well introduce it now, is that in the arachidonic acid pathway, there's a bunch of steps, but in one step, there's an enzyme called COX-1, okay, cyclooxygenase 1. And this is inhibited by aspirin, okay? One of the products of this is thromboxane A2, right? Thromboxane A2 is one of the products of this. So we can use aspirin to inhibit this process, but what's our downside? So the reason we use dual antiplatelet therapy, we can use it after a heart attack, we can use it for stents. Well, actually, not we can. It is absolutely indicated for at least 6 months after placing a stent to be on dual antiplatelet therapy. The first one's aspirin, which targets cyclooxygenase and it prevents that thromboxane A2 formation. But the second one, in the dual antiplatelet is called ticagrelor or clopidogrel. They're P2Y12 inhibitors, and we'll talk about that later. But the point is, even though those drugs can be used to prevent clotting, they're used to prevent clotting inside, of a coronary vessel you just revascularize. You don't want it to clot again, so you use dual antiplatelet therapy. Let's say you have peripheral artery disease somewhere, you might use dual antiplatelet therapy. If you have a stent placed, mechanical stents are prone to having coagulations forming on them. So not only do they put this substance on the stent to prevent this from happening, but they also provide dual antiplatelet therapy for at least 6 months. And you don't need to know, if you're in studying for step 1 and watching this, you don't need to know that. I think that's more of a step 2 and higher. At least for me, I wasn't tested on it until my step 2 prep. That dual antiplatelet therapy is absolutely indicated when using a stent. But so what's the side effect? Bleeding, right? That's what you're playing with. Brain bleeds, etc., vessel bleed, all sorts of stuff is what you're playing. You're playing with fire, right? So you only want to use this stuff when you need it. That's actually why back in the old days they would use aspirin for primary prevention. But some of the more recent clinical trials, especially in older adults, has shown that, well, maybe aspirin isn't supposed to be used for primary prevention. So in other words, if someone's never had a heart attack, should we use aspirin to prevent a heart attack? The data is starting to say no. It's not an absolute no, but you have to do a case-by-case basis, and you need to think, okay, is my patient a fall risk? Do I really want to give aspirin, which causes bleeds because of what we just described, inhibition of thromboxane A2? Do we want to give this to a patient that's a fall risk? Because what if they fall, hit their head, and bleed and die? Well, now I've caused this. That's iatrogenic. So these are some of the considerations we make, and it's directly related to the physiology. All right. So here's the normal structure of the endothelium. This is extremely important. So notice it's held together by tight junctions with parasites. And you have multiple layers that maintain the vascular tone, and you have a balance between relaxation and contraction. I want to underline a few important things here. Endothelin, angiotensin II are absolutely testable, particularly angiotensin II, because it's a part of an essential hormonal feedback loop. But we're not going to go into it. I just want to emphasize it. I want you to stick it in your head. Angiotensin II is important. It's a very potent vasoconstrictor. Please know that. All right. And a very, very important vasodilator is nitric oxide. Please, please, please remember that. Relaxation of smooth muscle happens from nitric oxide. Contraction comes from angiotensin II. The endothelium normally is held together by tight junctions, and there are pericytes that help maintain that basement membrane. All right. That's the histology. That's the relevant histology that I want you to know right now. Okay. So notice here is healthy. Down the middle is healthy. Okay. So this is healthy. Okay. Healthy. This is activated. Right? You have You have all these inflammatory factors. You have exposure of the exposure of the underlying basement membrane. You have platelet heat, et cetera, et cetera. You can see there's a lot going on here. It's a very inflammatory state. All right. And this is particularly important in acute respiratory distress syndrome. Okay, I had talked about it a bit in the Starling Forces lecture. So what happens here in this, what do you think could happen here? There's a number of bad things happening here. But first of all, you have increased vascular permeability. So fluid in the activated endothelium, which is an inflammatory response. So let's say someone has a bacterial infection or sepsis or something like that. These chemoattractants and cytokines, this widespread septic shock-like picture, this widespread inflammation makes the vasculature more permeable and fluid leaks out. Okay, because remember the equation for whether fluid leaks out or not, I'm not going to rewrite the whole thing, but it's based on 3 factors: permeability of the membrane, hydrostatic pressure, and oncotic pressure. Those are the 3 things it depends on. We're not concerned with oncotic pressure and not really hydrostatic pressure here. We're concerned with permeability. So what's going to happen? This inflammatory response, this activated endothelium, leads to permeability of the vessels, particularly around the alveoli. So what happens? Fluid leaks through the capillary into the alveoli. They fill with fluid. You can't do gas exchange, and that's called the acute respiratory distress syndrome. You get this hyaline infiltrate. Okay? And that's why you notice this paper comes from a COVID paper. What made COVID so deadly was how potently inflammatory COVID was. COVID generates inflammation, especially early COVID like Delta. It created such a potent inflammatory response. So that's just what I want to point out here. Normal endothelium, activated endothelium. And as a result of this vascular permeability, and this inflammation and these white blood cells coming in and all this stuff, that exposes the underlying, the underlying collagen injury. Remember we talked about? Platelets, von Willebrand factor will be bound to the collagen that'll link the platelets, and then going in the other pathway, there's tissue factor. There's factor 7 binding to tissue factor. There's all this stuff going on that can cause coagulation. And if you think about it, if the inflammatory response is systemic enough, you can get this systemic coagulation. You can clots forming everywhere in the body, and that's called disseminated intravascular coagulation. We're not going to go into detail about it, but again, I'm trying to highlight it in terms of physiology. Normally, the endothelium expresses these relaxation factors. There's a balance between contraction and relaxation. You don't have this inflammatory process. You don't have exposure of the subendothelium. An activated endothelium, whether it's from a direct like traumatic injury or inflammation, you get exposure for one reason or another. You get exposure of the basement membrane, and exposure of the basement membrane causes clotting, right? It's it's just physiology. You don't have to memorize it. That, for example, in sepsis, there's an increased risk of DIC. You don't have to memorize that. It's a inevitable physiologic consequence that if you have systemic inflammation everywhere, you have exposure of the basement membrane everywhere, you can get clotting everywhere. And that can lead to a microangiopathic anemia, but we're not going to worry about that right now. So here it is, the subendothelial matrix. You can see here's the exposed collagen, and it interacts with 2 things. There's glycoprotein receptor 6. Don't worry too much about that. And then there's von Willebrand factor. All right, through the GP1B. So a problem with von Willebrand factor or a problem with GP1B, and this is Bernard-Soulier, a defect in this. Okay, so let's say you suspect von Willebrand disease because the person's presenting like they have a von Willebrand issue and their platelets are fine. So you look at their platelets, they have enough platelets, and you're like, why are they having a bleeding disorder? And you check all the other coagulation factors and they're all normal. What you might want to consider is Bernard-Soulier, because if this receptor isn't working, it's as if you don't have von Willebrand factor. So it's like a qualitative defect, right? It's a qualitative defect, not a quantitative defect, which means you just don't have enough of something, because there are some versions of von Willebrand disease where you do have von Willebrand factor and it works, you just don't have enough of it. That's quantitative. This is a qualitative issue, right? Bernard-Soulier is a qualitative, the quality of the receptor, okay? The point is, these processes activate platelets, and the platelets will release serotonin and thromboxane A2 and ADP. All right? And this causes a forward feedback loop, and that activates other platelets. So when we use P2, there's a P2Y12 receptor not labeled here. That's what ADP activates, P2Y12. This we inhibit with their inhibitors, we'll talk about on the next slide. And then over here, you see thromboxane A2, we can inhibit this. We're not inhibiting its receptor, but what we're doing is we're inhibiting the actual synthesis because we're going to inhibit cyclooxygenase 1. All right, you can see here the G2B3A receptor binds fibrinogen, that binds to another 2B3A receptor. So you sort of get this fibrinogen platelet, platelet fibrinogen platelet, platelet fibrinogen platelet, blah, 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 blah. And all this is being held to the basement membrane by some von Willebrand factor. All right, von Willebrand factor. All right, and this is the collagen. Okay, so you get this network that's just forming like platelet, fibrinogen platelet, etc. All right, and that forms your network. And you can see how this acts as a scaffold because the coagulation factors, they don't just like say, I'm here, what's up? They have to recognize things. And one of the things well, at least the intrinsic pathway recognizes is von Willebrand factor. It stabilizes factor 8A. So like we said, aspirin's bleeding risk is mediated by inhibition of COX-1, leading to decreased thromboxane. However, we utilize this in dual antiplatelet therapy by pairing aspirin with P2Y12 inhibitors, such as ticagrelor or clopidogrel. The main difference is the reversibility, but you don't need to know that. P2Y12 is a G inhibitory protein. We talked about this in a previous lecture. You can review the arachidonic acid pathway lecture in the molecular biology neoplasia playlist that I have. But the point is P2Y12 is a G inhibitory protein that's activated by ADP, and that decreases cyclic AMP, right? Because it's a G inhibitory protein. It makes sense that it's going to decrease cyclic AMP, and that leads to platelet aggregation. So by inhibiting the P2Y12 with ticagrelor or clopidogrel, you prevent the activation of the inhibitory G protein that prevents the decrease of cyclic AMP and that prevents platelet aggregation. By using aspirin, you prevent thromboxane A2, so you prevent recruitment of platelets. Okay, so here's some selected pathophysiology. So like we said, von Willebrand factor doesn't just mediate adhesion to the subendothelium, but also stabilizes factor 8 of the coagulation cascade. So problem with von Willebrand factor can kind of affect both arms, though it's mainly going to affect primary hemostasis and bleeding time and that sort of picture. Now, stenotic valves, particularly aortic stenosis, can cause increased bleeding through an acquired von Willebrand factor disease. The triad of aortic stenosis, GI bleeding, and acquired von Willebrand factor is called Heyde syndrome. This is pimpable. I got pimped on this as a medical student, and I didn't know it. And it was it was like in the back of my head that I had read something about aortic stenosis and bleeding, and my attending on IM had asked me, well, what's the correlation there? Because we had a patient with aortic stenosis and GI bleed. So my attending asked me, well, this isn't what's going on in our patient. We already know what's going on. What is the correlation between aortic stenosis and GI bleeding? And here is the correlation. The strain of going through a stenotic valve, or it can be a mechanical valve, it can be a hypertrophied left. You guys, depending on where you're on your education, you might not know what HOCM is, hypertrophic cardiomyopathy. Anything that makes more shear stress on von Willebrand factor. Remember, von Willebrand factor, it's a multimer. It's kind of big. It's susceptible to shear stress, to mechanical distortion. Now, this distortion makes it more susceptible to being broken down. The protease that breaks down von Willebrand factor is called ADAM-TS13. Okay, it's the von Willebrand factor protease. And the strain of shear forces, no matter what the cause is, can lead to increased breakdown of increased breakdown by ADAM-TS13. So you can see here, there's a glycoprotein 1b receptor, von Willebrand factor, platelet, et cetera. You see, stuff's going on. In the presence of the protease, you can see that these von Willebrand factor multimers, they're well structured. They're organized. They're laid out very neatly. In the absence of ADAM-TS13, what happens? You get this really, really long, winding, tortuous formation, and that recruits too many platelets, and that's what we call bad, because that can cause thrombotic thrombocytopenic purpura. We don't want this. We want balance, as in all things. So what's the physiology that's important here? I want you to recognize that the atom TS13 normally is proteolytic on von Willebrand factor, and that keeps everything nice and ordered. In the absence of atom TS13, you get excessive clotting because you don't have anything. So it's like a bush, like a garden. Atom TS13 is the gardener, and it's not able to trim the bushes, so you get this nasty, unkempt hedge rather than this neat, beautiful little bush. All right. So to go back to the other example with aortic stenosis, it's what happens is that it makes it too easy for von Willebrand. So the von Willebrand factor goes through these stenotic valves and it gets destroyed. Or its conformation changes, so it's more susceptible to being broken down by the protease. So you don't get this picture or this picture, you get less hemostasis. All right, so it's as if you get it's like an excess of atom TS13, although it's not that the atom TS13 has actually gained function, it's just that the von Willebrand has become more susceptible to that function. And again, just illustrating, normally atom TS13 shears the von Willebrand factor, keeps it from the multimers from becoming excessive, and that keeps stable blood flow. In the absence of atom TS13 function, well, you can see what's going on here. Does it look like blood is really flowing? No. So there's three kinds of genetic von Willebrand disease, although I do want to emphasize it's more of a spectrum because there's so much polymorphism. In other words, there are so many different alleles in this gene that there's a wide spectrum of presentations. So type 1 is an autosomal dominant partial quantitative defect. So you might have one gene that isn't making, like you have to remember, you have two genes that code for proteins. One of them might not be working as well. So you get this autosomal dominant partial defect in the quantity. You may or may not actually exhibit the disease. Type 2 is an autosomal dominant qualitative defect. Most of what we detect falls under this category. That means there's a problem with the von Willebrand factor itself, even though your body makes a normal amount. Type 3 is autosomal recessive. Why? Because it's a total quantitative defect. So you don't need to just have one allele that isn't really making von Willebrand factor. You need to have two. All right, so it's a total quantitative defect. Now you can also acquire von Willebrand disease, like we said, not just from high flow states and mechanical valves. There are some drugs that can do it. Hypothyroidism can do it. Immunologically, it can happen. Antibodies or breakdown of von Willebrand factor can occur. It can happen in association with a lot of cancers. And like we said, Bernard-Soulier is a dysfunction of glycoprotein 1b. All right. So now we come back to this, and this does not look so scary anymore, right? You have your normal healthy endothelium. When it's damaged, the collagen is exposed, and there's interactions with von Willebrand factor and platelets, and the platelets are activated. They release ADP, serotonin, and thrombin. Sorry, not thrombin. Serotonin, thromboxane, and ADP, and that leads to this cascade of activation. The platelets aggregate, they form fibrinogen networks, and then that acts as a scaffold for the second part of the coagulation cascade. Meanwhile, you have some things that can go wrong, either with let's say you don't have enough platelets, etc. That's kind of intuitive. If you have problems with von Willebrand factor, you can have a bunch of issues because you won't get this primary hemostasis process gets stopped way earlier. And you can manipulate this, the physiology of this using drugs like P2Y12 inhibitors or aspirin. All right, you guys have got this. See you next time.